Good morning. Today we're going to talk about NanoNeedle technology and how applicable it is for hand and wrist surgery. Now, what you'll see compared to the first generation of nanoscope is the second generation here. And immediately what you'll notice is that the bulbous end has been removed. And you can see we have this thread pattern here for ergonomics to let you know where you are in space. And now you can see that you can literally rotate this like a pencil. And using the nano grip, this gives you even firmer and more precise control distally. In addition, what you'll also notice is instrumentation. We have the low flow sheath and the high flow sheath cannulas. The low flow sheath cannula is a 2.4 millimeter outer diameter cannula, and the high flow sheath is a 3.3. But what's different is that you'll notice is the ratcheting on the actual nanoneedle itself, where the actual nanoneedle will lock into the cannula and not piston out of the joint. So now here we have the straight high flow sheath cannula, and what you'll see here is as this comes on, there'll be an audible click, and that gives you secure camera interdigitation within the cannula. You can see it doesn't piston out as I'm pulling this out, and this will now allow this to lock into place while you're doing your wrist or finger joint arthroscopy. So basic dorsal wrist arthroscopy starts off with the radiocarpal joint arthroscopy, and the gateway into the wrist is the 3-4 portal. So if you feel listus tubercle and just come distal, there's this soft spot, and that's where we're going to mark that. Our working portals tends to be either the 4-5 or what I like to do is the 6R portal. It gives you a little bit more latitude when you're going radial to ulnar. And so I will feel the 6R tendon and just come radial to this and mark that. And you'll see that there's an inclination given the inclination of the distal radius. Once we found that, we want to work on our mid-carpal portals. Now, the most dorsal ulnar structure on the wrist is a triquetrum. So if you find the triquetrum and just come radial to this, there'll be a soft spot right there. And that soft spot there is the ulnar mid-carpal portal. For me, whenever I'm doing mid-carpal arthroscopy, I always make the ulnar mid-carpal portal first in case there's a scapholunate ligament problem, and if so, it makes the radial mid-carpal portal harder to find. As I find my 3-4 portal come just distal, there's a soft spot, and that soft spot will allow me to find the radial mid-carpal portal. But as I said, sometimes the anatomy is out of place, and so once I've put the camera in the ulnar mid-carpal portal, I can find the radial mid-carpal portal. In terms of accessory radiocarpal joint portals, we traditionally use the 1-2 portal, and this is nice, for example, for radial styloidectomy. One of the issues with the 1-2 portal, however, is the close proximity of the radial artery. And so recently we described the 2R portal, which is just radial to the second extensor compartment, and this actually takes you further away from the radial artery and hence is safer, for example, if you're doing a radial styloidectomy. Now we found the soft spot for our 3-4 portal. We're taking a 20 gauge needle and we'll just come straight in, and you can see the inclination of the needle. It doesn't come in horizontal, it slightly comes from dorsal distal to volar proximal. And once we found that, we'll then take a knife and just make a small transverse skin incision. For me, I like to make transverse skin incisions. It's cosmetically better for the patient. However, some people like to make a vertical skin incision so you can enlarge the portal. So once we're through the skin, we can spread down. Now, one of the advantages of nanoneedle arthroscopy is that the smaller low flow sheath cannula is only 2.4 millimeters. So in effect, it's safer for the tendons. Here today, we're using the high flow sheath cannulas. So once we're in, we'll now take the nanoneedle. So the nanoneedle cannula is in the 3-4 portal. I've made the 6R portal here this is our working portal. And now what you'll see, one of the differences of the second generation nanoneedle technology is actually how the nanoneedle itself clicks into the cannula. So it doesn't actually fall off the cannula. So as I push this in, there's a positive stop and you'll feel it and hear it. So it's both tactile and audible in terms of your latching onto the cannula. And now typically when you're into the wrist, the first thing that you see is the volar capsule. And so you back the cannula out, and there you are. Now you have your view of the joint. So again, when you're first in, this is what you see. Back it out, and now you can see how I'm holding the cannula. I'll use my long and ring finger as a tripod so I don't fall out. You can also add the nano grip if you want for comfort. And so if there's some distortion on the camera, just wipe it in the soft tissues. Sometimes there's fluid in there that we'll need to do the automatic washout technique to dry it up. And so here now you can see the volar capsule, and you can see there's a little bit of fluid in the joint, so we're just going to dry that out a little bit, and then we'll do our wrist arthroscopy. So here you can see we come over. There's the shaver. So it's very direct and it's very specific. And that's the beauty of NanoNeedle. It's small portals. You can see there's no weight actually as I'm holding the actual camera. It's very ergonomic in terms of what I need to do. And now you can see I've got my finger on the shaver. It's a 2mm shaver. And so that this gives you plenty of power and accuracy. And you can see here how we're literally watching the camera come straight to us and the shaver, and I can debride the capsule directly looking at it. It's very precise, very deliberate motions within the wrist, and you can see the actual space. You can see the carpus above me and below me, the distal radius, and we have a tremendous amount of space because of the NanoNeedle being a 1.9mm camera. This technique is also important, for example, for arthroscopic synovectomies, for dorsal ganglions, for more advanced arthroscopy, if we're doing an arthroscopic dorsal SL capsulodesis. And you can see how it can come across. And so by looking at it directly, and if you do want the angle, you have the actual angle cannulas as well. The 10-degree cannula will also give you another view. But you can see here, we can see everything. And as we come across to the ulnar side, we'll get into the TFCC. So back to our diagnostic arthroscopy. Okay, you can see here, we'll just back it out slightly. And so what we're looking at first of all is the radial structures. So we got the radiuscaphoid capitate and long radiolunate ligaments. Scaphoid above us, distal radius, scaphoid facet below. Now, as we come across, you'll see this subtlety. Look at the scaphoid at the north side. And if you come across here, you'll see the membranous portion of the scapholunate ligament. Remember, that's not the volar or dorsal, that's the membranous. But there's a step off. Do you see that? There's scaphoid is higher than the lunate on the right side of the screen. And that should be a little telltale sign that there may be scapholunate ligament pathology. And that's why I mentioned you make the ulnar mid-carpal portal first, because the scaphoid is more distal, making it harder to make the radial mid-carpal portal. Now look at just below the membranous portion of the scapholunate ligament. You'll see that there's a ridge. That's the intersulcus ridge. So scaphoid facet is here. Lunate facet is underneath this. And this is why when you see those intra-articular distal radius fractures that come through the scapholunate interval or through the intersulcus ridge, you want to be wary of potentially a scapholunate ligament injury. So now we come underneath. You can see we slide effortlessly. There's no gouging of the cartilage. And now as we come across here, you'll see the lunate above us, the lunate facet below us. And as we come over here, now you'll see the TFCC. And so when I push, you can see that fluid pooching out. That is basically the foveal sign when I'm pushing on here. So that will tell you, for example, of TFCC pathology, but you can see exactly where you are. So you can see we have some synovitis in the ulnar gutter that needs to be debrided. Now remember, if the wrist is small, you use the 2.4mm cannulas, okay? Today we're showing the 3.3mm high flow sheath cannula. For example, if you want to do wet arthroscopy, we're doing dry arthroscopy, and so you can alternate between the 2.4 and the 3.3mm cannulas. Okay, so now you can see, so here you can see the TFCC below us. You can see how I'm able to manipulate this with the shaver. But here you can see we have synovitis in the ulnar gutter, and you always see this, for example, with TFCC pathology. But remember, you have to marry your clinical examination with your arthroscopic findings. Sometimes patients will have no ulnar wrist pain, and so this is just an incidental finding. But here you can see all this synovitis, and this actually has to be debrided to allow you to do your TFCC work. Now, this is the 2mm shaver. You can also use, for example, the torpedo shaver, which is a 3.5mm shaver, which is actually more aggressive and very efficient in debriding the synovitis. So I typically start off with the 2mm cannula, and then if I have to do a lot of synovectomy, I'll switch to the torpedo. Now, don't forget to get all this synovitis here, because this is where, for example, the patient may have a UT ligament split tear, and it's hidden underneath all this synovitis. So this all has to be shaved to allow you to get a better view. So here you can see I've brought the NanoNeedle across, and we've debrided the synovitis. And now look here. Okay, this are the ulnar carpal ligaments. Now, we normally have the prestyloid recess, but sometimes there'll be a split tear. And the only way that you'll delineate that is by debriding the synovitis. And once you delineate the synovitis, if you then do see a split tear, which is usually where I'm going right here, that's when you'll debride this, and then you'll repair this through a method of your choice. Now, how do we look at TFCC pathology? So there's basically a few intraoperative maneuvers. We've done the clinical examination. I always do an exam under anesthesia, compare the uninjured side to the injured side in the operating room. And now what I'll do is take the probe. So the probe comes in, and there's a few tests that we do. So the first one is the trampoline sign. There should be a natural buoyancy to the TFCC. So as you see, when I push this up and down, how it springs up. So that's number one. The second test is the hook test. So you come under, and you can see how I can actually get underneath this, and I can actually lift this up. Now remember, in some patients, this can be normal, so you have to look at the clinical examination. But here you can see I can easily get underneath this, suggesting that if this patient, for example, complained of ulnar wrist pain, I don't really see a good peripheral tear, but this patient may actually have a partial foveal tear, and the only way to diagnose that really is through DIJ arthroscopy. The other test that you can do from the radiocarpal joint is a suction test. So you put the suction in, and you basically simply from here just turn the suction on, and that will allow you to lift the TFCC up. So now you can see I have the actual shaver on, and then I'll turn the suction on, and you can see on this one, there actually is minimal lifting up of the TFCC. So here the suction test is negative. So now we're going to do our mid-carpal arthroscopy. So we found the triquetrum. Remember, that's the most dorsal ulnar structure on the wrist. If you come just distal and radial to the triquetrum, we'll drop in this soft spot. And that soft spot is the ulnar mid-carpal portal. So we're popping straight in. You'll notice the inclination of the needle is different. It's much more horizontal compared to the radiocarpal joint, where we have to take into account the inclination of the distal radius. So once we're through the skin, we're spreading, and then we're going to drop into the joint. And you can see we just dropped in. It's a firm endpoint, and we just open up the capsule, and then we take in our cannulas. So then the cannula just comes in. Remember, you'll see I have my thumb here. My thumb actually acts as a gateway, so I don't lose direction, because it's very easy for the skin to move. So I've got my thumb right there, and then I come just straight onto my thumb, and I'm into the joint. And you can see once we're into the joint, we're ready to go. In comes the NanoNeedle, and remember, again, you'll have this tactile and audible click. So you know that the NanoNeedle is actually ratcheted into the cannula. You can see we're slightly off here, but as I hold the cannula and push, there's that audible click, and now I'm ready to go. And now I can take my hand, and you can see I'm holding it. My long and ring finger is acting as a tripod. The first thing that I always see is white. That's the volar structures, and I'll pull the cannula back, and now you can see I'm in the actual mid-carpal joint. There's a bit of fluid in here, so we're going to clean that out, okay? And so the first thing that you want to do is find your landmark. So find the lunate, and then find the capitate. There you are. So there you can see now you're safe. So once you found the lunate and the capitate, you can turn your hand to the right. And so now you can see there's a step off there between the lunate and the triquetrum, but you don't adjudicate instability from this portal. You come on from the other side. And if we go to the other side, look at that step off. So you can see the scaphoid on the left and the lunate on the right. And remember, we had that sort of clue from the radial carpal joint when I scoped this, and we saw that step off between the scaphoid and the lunate. And this is why you make the ulnar mid-carpal portal first, because now look at that tight space between the capitate above and the scaphoid below. That can be very hard to make, but now using the NanoNeedle, we can see exactly where we need to go. We can push on the skin. You can see as I'm pushing, so I'm slightly off on my portal. There I'm on the scaphoid, and there I'm on the capitate. So now I can see that and come directly in with the needle. So it's very safe, very deliberate. All right, so now you can see I've come in with the needle right above the scaphoid. So you can see there we are. So capitate above us, scaphoid below us. And so now what I'll now do is make a small transverse incision, spread down, and this will allow us to bring, first of all, our shaver to shave out the joint, and then we can do our arthroscopic examination of the wrist. So once we're through the skin, we're now just going to bluntly spread down, and we have the NanoNeedle in the actual wrist, which will allow us to see exactly where we're coming through. So there we are. So now we're through. we're just going to open up the synovial capsule just for about 5 to 10 seconds to allow it to distend, because invariably when you take this out, the capsule will close. And now from here, we can bring in the shaver and debride the joint. All right, so now you can see it's a little bit wet in the joint, so we're just going to shave this out. Okay, usually the shaver works just great, but sometimes we'll have to do the automatic washout technique as well. But here you can just see, just with a little bit of shaving, okay, we're just taking out the fluid. We can actually see everything we want to see. So you can see there the step off between the scaphoid and the lunate. So if this patient was complaining of radial-sided wrist pain, we would be worried about potentially having a scapholunate ligament problem. And so here we're just debriding the synovitis, and this is an important step because without this, if the scar tissue prevents you from reducing the scaphoid and the lunate, then any soft tissue reconstruction or repair will not work. So we want to debride so we can get this joint reduced. So now I can see the scaphoid and the lunate. Now we'll take a probe. And so now when I'm looking at this, what am I looking at? Number one, I'm looking at the cartilage. Is it arthritic or not? The second thing I'm looking at is where's the injury? So here's the dorsal, so I can twist this, and there's different classifications that you can use. So there's a little bit of dorsal play, but otherwise not too bad. And now I come volar, and you can see here the volar side is not too bad. But what's important for me to notice is that this is reducible. Look how easily I can reduce this. So if this patient had a scapholunate ligament problem, I could be thinking of an arthroscopic volar or dorsal repair or both, or a ligament reconstruction if it was a chronic injury. But these are the important things that NanoNeedle arthroscopy will give you. It'll tell you, number one, where the pathology is, dorsal, volar, or through and through. Remember, this is the membranous portion, and we saw a membranous tear from the radiocarpal joint. It'll also show us, is the carpus reducible? And sometimes there's scar tissue. You can see we debrided the scar tissue. And secondly, it'll show us the cartilage. Look at that capitate. Capitate's pristine. Scaphoid looks good. Lunate looks good. Okay, so that's the sort of information that you're getting from mid-carpal arthroscopy. In addition, if patients have a ganglion, where is the ganglion? So if I take the nanoneedle and turn this around, and you can see how ergonomic it is, you sometimes have this synovitis and the dorsal capsule right in this area here, what I'm showing with the probe. And so now what we do is bring the shaver and shave all this area down. This patient doesn't have a ganglion, but that's sort of top tip there. To complete our mid-carpal arthroscopy, it's critical that we take the camera and come from the radial mid-carpal portal looking to the ulnar side. And you can, again, have that audible and tactile feel. And one thing that you may have noticed during this demonstration is that sometimes with generation 1, the cannula and the camera will be disengaged, but you can see how robust this articulation is. And so that is not occurring anymore, which is certainly very nice during the case. So now we found our landmarks for the wrist. So remember, here's scaphoid, here's lunate, look above, there's capitate. Come to the ulnar side, and there's the LT. Okay, so you can see the triquetrum and the lunate. Now remember, when we first looked at this, there was a big step off because the camera was pushing this down. So now I'll bring in my probe, and what am I looking at here? I'm looking, for example, if this patient had ulnar wrist pain, do they have LT pathology? So you can see here's the lunate. It's a little bit mobile. And now when I put this probe in, it probably opens up a little bit more than the scaphoid side, but it's actually not too bad. There's the volar side. And then I'm coming on to the dorsal side. And you can also see the synovitis. Go where the synovitis is, and here we can shave this. The other thing that I want to see is here. Now, this is the whole reason why we do wrist arthroscopy. This patient has a Holt lesion, which is hamate arthrosis, LT instability. Look at the hamate here. This is something I wasn't suspecting coming in, but you can see this is not smooth at all. So this patient actually has pathology over on the hamate. So again, nothing I was suspecting coming into this cadaver, but the nanoneedle examination gives you the answer of why this patient potentially may be having ulnar wrist pain. You can see that this is not smooth compared to the cartilage there on the capitate. Now, another little trick here is STT arthroscopy. People ask, how do you do this? So it's actually very straightforward. You're in the radial mid-carpal portal. Here's the scaphoid. Okay, so follow the scaphoid. Now, the mistake is to follow the scaphoid and go up here because you're going to hit the capitate. So stay on the radial side of the scaphoid, drop your hand, and you'll see that little spot right up there. So here's the scaphoid. So we're going to hug the radial side, and we're going to drop our hand. And you can see as we're coming up here, there's the STT joint. And you can see how simple it is. You can see the beautiful anatomy of the ligaments inserting right there in the distal pole of the scaphoid. So if this patient had, for example, STT joint pathology, that's how easy it is using NanoNeedle. And now remember, with the 2.4 millimeter cannula, it actually allows you to get into there seamlessly. And then with the 2 millimeter shaver, you're working in the tight spaces, which initially were harder with traditional arthroscopy. You'll see during this demonstration, we've done dry arthroscopy. There's numerous advantages of dry versus wet arthroscopy. What are the advantages? Number one, people argue that you can't see with dry. Well, I think I've shown you during this demonstration, the visualization is actually pretty easy. And if there is fluid in the joint, we do the automatic washout to get your debris. But the real game changer for me has been allowing us to do more complicated work. For example, fracture fixation. We're not worried about soft tissue extravasation. We're not worried about, for example, compartment syndrome with the distal radius fracture. In addition, it allows you to see all the pathology. So for example, if we're doing bone grafting or fusion procedures, with the fluid, it can sometimes wash out your graft. However, when you're doing this dry, the fluid isn't washing out the graft. Admittedly, if you are using radiofrequency ablation, you have to have fluid. So you, for example, do not have chondrolysis and you don't have thermal heating up of the actual joint. The other advantage of doing dry arthroscopy is when you're combining this with mini open procedures. When you do it wet, the soft tissues get engorged with fluid and it makes tissue plane dissection much harder. However, with a dry arthroscopy, you can actually work through the soft tissues and they're not distorted with fluid extravasation. So we've done radiocarpal and mid-carpal arthroscopy, and we've probably spent about 20 minutes here. If you actually look at the skin and look at the wrist, all you see is the portals. There's no soft tissue extravasation, there's no swelling. And so especially if you're new to arthroscopy or if you're going to do longer procedures, this is critical. You can see from the patient's perspective, there's no big soft tissue swelling. So for example, their pain may be less. But if you're also going to do now open procedures, essentially the soft tissue planes haven't been distorted apart from the 4 portals that we've created. So another advantage of dry wrist arthroscopy.